Okay. Yeah.
Okay. A very fine good evening and welcome to the IB class Genesis series. Today we have the session 1 on the topic Bony Pelvis. We have with us Dr. Nurul Ameen, Associate Professor, Department of Obstetrics and Gynecology, Government Medical College, Calicut. Hearty welcome to you, sir. Before we proceed further, a point to the audience: any doubt or queries during the class can be asked in the comment section. Now I hand over to Dr. Nurul to proceed with the class.
Thank you. So good evening all. So I've been asked to take a class on the pelvis, which has an importance in obstetrics. So compared to the maternal pelvis and its relevance in obstetrics. So usually what happens in the exams, you're given the pelvis. So there are some points which you have to remember. So whenever you are given a pelvis, there is a way of holding it. So pelvis is always held in its anatomical position. So though we have a tendency to hold it, I hope it's visible. So instead of holding it straight like this, usually the pelvis in anatomical position is actually inclined forwards. That is, the anterior superior iliac spine should be in the same plane as the pubic symphysis. Or the best way to say is, suppose if you have a wall, if you put the pelvis like this, so these two should be in the same plane, the pubic symphysis with the anterior superior iliac spine. So that should come in the same plane. So when it comes to the same plane, you can realize that it is actually bent forwards. Pelvis is bent forwards. Can you see this? Hello? Yeah. So you should hold it in such a way that it is bent forwards like this. In a way, you can say facing the examiner. The hollow of the pelvis should face the exam. So coming back to what the pelvis actually is and its significance. So it is a group of bones which is articulated. So a pelvis actually means a basin. So the Latin meaning of pelvis is a basin or a container. So it contains some organs which are found in the pelvis. So the bony pelvis, you can see, is made up of 4 bones. There are 4 bones and 4 joints. So the bones that the pelvis is made up of are 2 innominate bones, that is unnamed bones, or the hip bones. That is the innominate bones, 2 of them, the right and the left, and then you have the sacrum. And at the tip of the sacrum, you have the coccyx, which is usually articulated with the sacrum, as usually aged people. This is how you can differentiate well in a aged pelvis. So this is how the pelvis is made up of. What is pelvis is made up of? Coming to the joints. So there are, as I said, there are 4 bones and 4 joints. The first joint that you come across here is a pubic symphysis. Pubic symphysis, the bone is the joint with the 2 pubic bones, the left and the right. So it is a fibrocartilaginous joint. And then you have what's called as the sacroiliac joint. That is the right and the left sacroiliac joint between the sacrum and the iliac bone of the innominate. So the innominate bone is actually a bone which is fused. 3 bones are fused to form the innominate bone. It's the iliac. Then you have the pubis, and then you have the ischium. So the 3 bones which together make up the innominate bone. So you have, as I said, then you have the sacrococcygeal joint. So the 4 joints and 4 bones. So then coming to important part in obstetrics. In obstetrics, the importance of the pelvis is very much. You must have seen. So when you're coming to your postings and all, people talking about the pelvis. Is the pelvis assessed? How is the pelvis? Is the pelvis adequate? Is it inadequate? What is a cephalopelvic disproportion? What's a contracted pelvis? These are the questions which you will usually hear in the obstetric wards and the labor rooms. So it has some important obstetrical significance. So coming to the obstetrical part of the pelvis, can be broadly divided into two important parts. That is, you can see in this part is the pelvic brim. This part is the pelvic brim. Understand? So still there is some part of the pelvis above that. That is called the false pelvis or a greater pelvis. False pelvis or the greater pelvis. The true pelvis is what is inside that, below that. It is a true pelvis. So, does this the false pelvis or the greater pelvis has any obstetrical significance? Not much. So, it doesn't have any obstetrical significance. Obstetrical significance is what lies below the brim. That is the true pelvis that has obstetrical significance. So, coming to the parts which are important is you have we describe the pelvis in terms of planes and diameters. So here you have what's called as, we've started with the pelvic brim. You have the pelvic inlet. We say there is an inlet for the pelvis, then there is a cavity, and there is a outlet. This is the pelvic outlet. I'll come into details of this. So you have an outlet, you have a cavity, and you have an inlet. Between the inlet and the outlet is the cavity of the pelvis. This is how you divide pelvis into. And then coming to, that is all these are with respect to the true pelvis, because that is what is obstetrically significant for us. So coming to the inlet. Inlet is also called the brim of the pelvis. So you can again say, you can hear the people say that the head is at the brim. That means the head is near the inlet. So the inlet is, which is an important plane of the pelvis. So there is a plane of the inlet, or it's called the superior straight of the pelvis. So this inlet is, they'll ask you usually, the examiners want you to tell you what forms the inlet. So what forms the inlet actually is starting from the pubic symphysis. So this is the pubic symphysis, the superior part of the pubic symphysis. Then you have the pubic crest. Crest is something, the mountain is a crest. So something like that. There's an elevation here. That is the pubic crest. Then you have a spine. You can see the projection here. This is the spine, pubic spine. So pubic symphysis, pubic crest, pubic spine. Then you have the pectineal line. There's a pectineal line. So you can see this, the pectineal line. We get something for you. Yeah. So this is the. So we start with the pubic symphysis. And we said there is a pubic crest. Then we said there is a pubic spine. Then you have the pectineal line. So at the in between there is something called as eminence. This is called the iliopectineal eminence. Iliopectineal eminence. Then it continues. That line continues. This is called as arcuate line. Arcuate line. The whole thing is called as the iliopectineal or iliopectineal line. Iliopectineal line. Pectineal line, arcuate line, iliopectineal line. Okay, so this is the, we are coming to the brim or the inlet. What is the brim made up of? We start from the pubic symphysis, pubic crest, pubic spine. Then you have the pectineal line. Then you have the iliopubic eminence. Then you have the arcuate line. Then as we go posteriorly, you get the sacroiliac joint. Here is the sacroiliac joint. Then it moves towards the sacrum. It is the alae of the sacrum or the wings of the sacrum. Then there is the promontory of the sacrum. So the sacrum, the first sacral vertebrae is broad, and on the top of it you have the margin. The margin anteriorly, the margin is called the promontory because it juts inside. The promontory is something which juts inside. So that is a promontory, a prominence in the land. Suppose if usually a rock which is seen in the waters, it's called a promontory, a projection. Similarly, here you find that is jutting inside the pelvic cavity. That's why it's called the sacral promontory. So again, can we trace it back the same way? So after sacral promontory will be the sacral ala or the wings. Then you have the sacroiliac joint. Then you have the arcuate line. Then you'll have the iliopubic eminence. Then you have the pectineal line. Then you have the pubic spine, then you have the pubic crest, and the pubic symphysis. So this forms the inlet or the brim, pelvic inlet or the brim. This is what it's made up of. So this is usually in a female pelvis. There are different types of pelvis that you can see. So 50% of the women will have a gynecoid pelvis. Then another 25% will have an anthropoid pelvis. 20% will have an android pelvis, and 5% will have platypelloid pelvis. There are different types of pelvis based on the anatomy. So commonest is gynecoid pelvis. So this is a gynecoid pelvis, where you can see it is a round shape, the almost round with slightly transversely oval. So that is what you see in a gynecoid pelvis. Understand? So the transverse diameter is slightly larger than the anteroposterior diameter. That makes it almost round but slightly transversely oval. So this is a good gynecoid pelvis. You can use to identify the gynecoid pelvis. Say if it is an anthropoid pelvis, it will be, what you see is anteroposteriorly it will be oval. So it means anteroposterior diameter will be longer than the transverse diameter. In the android pelvis, what you see is a heart-shaped inlet. So this promoter will be more inside. So it will become making it a heart-shaped. That is an android pelvis. And the last type of pelvis is platypelloid, where it is horizontally oval. Okay, it's transversely oval. So these are the 4 types of pelvis. But normally we see the gynecoid pelvis the most common in the females, and this is a very good gynecoid pelvis. You can see it's almost round, slightly transversely, slightly bigger, longer than the anteroposterior. This is about the inlet. So whenever we talk about different parts of the pelvis, we also talk about some important. We measure the pelvis. We have learned to measure the pelvis, which is how we know whether it is adequate. So one of the ways we do is we have many diameters of the pelvis. So here you find, coming to the inlet, we have different diameters of the inlet. So mainly you have 4 important diameters in the inlet. So how do you define, measure different diameters is, you have anteroposteriorly, you have diameter transversely, and then you have 2 oblique diameters. This is how it is measured. So coming to first thing is what are the anteroposterior diameter of the inlet. So when you talk about anteroposterior diameter of the inlet, normally we are not able to directly measure all the diameters. There are significantly 3 important diameters that we know anteroposteriorly in the pelvis itself, that is at the brim. The inlet itself, there are 3 important diameters that we should know. So first thing that we can actually measure is something called the diagonal conjugate. So what is the diagonal conjugate? It is the diameter from the middle of the sacral promontory. We said sacral promontory is this abutting part of the anterior margin of the upper border of the first sacral vertebrae. So the center of the promontory to the lower margin of the inner surface of the pubic symphysis. So this is one thing that I can measure. I can put my hand in a woman who has come to labor, and then I can touch the sacral promontory with my middle finger of the right hand, which I used to do the PV, and then I can see that I can feel the pubis bones, symphysis pubis. So at the lower edge of symphysis pubis, that is the lower margin. I can mark this and then measure. So I can remove my hand, and then I know that this part has touched the sacral promontory, and this part I can mark the what is it called as the diagonal conjugate. So diagonal conjugate normally is around 12 centimeters. So I'm going to tell you the measurements also now. We'll revise it later. So this is again 12 centimeters, the normal diameter. That is the longitudinal diameter. So that is one thing which we can measure. But there are 2 diameters which we can't measure. We deduce from the longitudinal diameter. That is, one is the obstetrical conjugate, and then you have the true conjugate. The true conjugate is what we call the conjugata vera. Conjugata vera. Vera means true. Verus is true. So true conjugate or conjugata vera, or anatomical conjugate. That is actual, what you see is from the sacral promontory to the upper margin of the pubic, center of the upper margin of the pubic symphysis. That is the measurement. That is called the true conjugate or conjugata vera. That is around 11 centimeters. That is normal. So there is another conjugate which is called the obstetrical conjugate, which is very significant because that is the smallest diameter. So when you take the posterior surface of the, I can take that this is the posterior surface of the pubic symphysis, though that area which is the most prominent here on the posterior surface, again this is the most prominent, I can feel the most prominent area. That is from there, if I am again turning it, from there if I draw a line to the promontory, from this point on the posterior surface, which is the most prominent, if I draw a line from here, the same point as we talked about, as we took for longitudinal and anatomical, the same point, the center of the promontory, to the most prominent region in the posterior surface of the pubic symphysis, that is called as the obstetrical conjugate. So anteroposterior, the shortest diameter is formed by this because you're taking the most projecting area on the posterior surface. That will be the most shortest. This is the shortest diameter. That is called the obstetrical conjugate. So it is around 10 to 10.5 centimeters. So we said there are 3 diameters in the anteroposterior diameters in the pelvic inlet itself. So in that there we talked about a diagonal conjugate which we can measure. We talked about a true conjugate or conjugata vera, which is the actual diameter. Then we talked about the most significant diameter, which is the obstetrical conjugate. So we can measure diagonal conjugate. And how do you deduce this thing? It's we said the obstetrical conjugate is normally, the diagonal conjugate is normally 12. So we said obstetrical conjugate is 10 and the true conjugate is 11. So you have to use the same this thing. So if whatever the diagonal conjugate you measure, if it is 12, then you have to reduce 1 centimeters to get the anatomical conjugate, and 2 centimeters should be deducted to get the obstetrical conjugate. So that is the anteroposterior diameters of the pelvic inlet or the brim. Next comes the, what is the transverse diameter? Transverse diameter is again, it's not the central part of the brim, but what you have to do is you have to take the farthest point on the pelvic brim transversely. So that will be on the iliopectineal line. So the iliopectineal line is what starts from the pubic symphysis up to the sacroiliac joint. So this line, the farthest point on these two should be taken. So what's the distance between that is what is called as the transverse diameter of the inlet. So if you want to know the transverse diameter of the inlet, it is not exactly at the center. It will come slightly posterior because posteriorly it is more wider. The farthest point will be more posterior. So it's so we said the anteroposterior diameter is actually the conjugata vera or true conjugate was actually 11 centimeters. So ideally, if you take a center, it should be 5.5 centimeters, but it's not where the transverse comes more posteriorly. That is 7 centimeters from the pubic symphysis. So it is divided into 7 centimeters anteriorly and 4 centimeters posteriorly. So that is where the horizontal diameter or transverse diameter crosses the brim. So the transverse diameter of the brim is actually say it's around 13 centimeters. It's around 13 centimeters. Then we have the oblique diameters. I said there are 2 oblique diameters. So if there are 2 oblique diameters, one is right and one is left. How do you say it's right and left? Always the pelvis, when you talk about the pelvis, you start from the posterior part. So the posterior part is the oblique diameters always start from the sacroiliac joint. Sacroiliac joint to the iliopectineal eminence. So we talked about an iliopectineal eminence here. So from the iliopectineal eminence to the sacroiliac. So actually should start from the sacroiliac joint to the iliopectineal eminence. So if it is a right, then it is the right-sided sacroiliac joint to the iliopectineal eminence. If it is left, then it is a left-sided sacroiliac joint to the iliopectineal eminence. So the side is determined by the posterior part. So posteriorly from the sacroiliac joint, the diameter which starts is called the right and the left depending upon which side it is. So you have 2 oblique diameters, you have 3 anteroposterior diameters, and you have a transverse diameter. So these are the diameters of the inlet. So I'll tell you a very easy way to remember all these later. So I'm just telling you I'm describing the different diameters and we'll try how to memorize it easily. Then comes the cavity. We said that between the inlet and the outlet is the cavity. So first we'll go to outlet and finish, then we'll come back to the cavity. The pelvic outlet is again, you can see this, you have the coccyx. This is the coccyx. The end of the sacrum, which starts with the coccyx. Then you have the pubic symphysis here. Pubic symphysis. On two sides, you can see the ischial tuberosities. This is the ischial tuberosities. The bone on which we sit is the ischial tuberosities, the broad area, ischial tuberosities. So this is called this forms a diagonal or diamond shaped or rhomboid outlet. It's actually a rhomboid. So you can divide, if you draw a line between the two ischial tuberosities, you can divide into two triangles. Can you see that? You can divide into two triangles. So that is how the outlet is. This is actually called the anatomical outlet, but that is not what we need. We have a importance is the obstetrical. There's an obstetrical outlet which is slightly different from the anatomical outlet. So when you see the bone, this anatomical outlet is as I described now. Whereas there is an obstetrical outlet which you can see this projection. This is the ischial spines. So I hope you remember your anatomy classes. You can see this. I'm actually showing it inside. So this is the ischial spine. Ischial spine is a very important landmark for obstetrician. There are two iliac spines here. So this, ischial spines. So this ischial spines area or the plane is what is important, which determines the obstetrical outlet. So obstetrical outlet starts from the ischial spines, then you have the pubic symphysis, and you use the sacrum instead of the coccyx. You leave the coccyx aside, because the coccyx is not important for obstetrics. Coccyx actually moves aside when the patient is in labor. So what you need is the sacrum. So the difference between an obstetric and anatomical outlet is obstetric outlet, we say it is the end of the sacrum, then the ischial spines, and then the lower part of the pubic symphysis. Whereas when you talk about anatomical, it is the coccyx, it is the ischial tuberosity, and then it is the pubic symphysis. So there is a difference between the anatomical outlet and obstetrical outlet. So we described the pelvic brim, we described the outlet, and in between these two you have the cavity of the pelvis. So in the cavity of the pelvis, again we divide into two important parts. It's actually called the actual cavity. Some people describe the cavity as the area between what is called as the brim and the obstetrical outlet. That is more significant. So the area of the obstetrical, below the area of the obstetrical inlet is just called the mid-pelvis. So this is the division of the cavity of the pelvis. So I'll tell you why it is important. We'll come to it. So coming to the mid-cavity. Mid-cavity, what is important is, what you see in the mid-cavity is cavity of the pelvis. You can find the pubic symphysis. If you take how we can use the diameters of the cavity. Diameters of the cavity is pubic symphysis here, the center of the pubic symphysis. From the center of the pubic symphysis, if you take a plane which will go from second and the third, between the second and the third sacral vertebrae to the center of the pubic symphysis, there you can find a wide dimension pelvis. The pelvis is wide here. So from this area to the posterior surface of the pubic symphysis, center of the posterior surface of pubic symphysis. This is a wide area that is called the plane of greatest pelvic dimension. Here there is a plane of greatest pelvic dimension. It is not having any obstacle significance because it's greater. You don't worry because it's great. But what is important is the plane of the least pelvic dimensions. That is the limiting plane. That is what you want to know. So there is actually something called as a greater plane of the greatest pelvic diameter, where the diameters are very wide. So in that area, we actually take the cavity or the dimensions of the cavity. So here, what you find is there is an anteroposterior diameter, like we said, there is a transverse diameter, and there is an oblique diameter. All the diameters in this mid pelvis is equal. It's perfect round or a circle. So you get all the diameters around 12 centimeters here. Okay, so all the diameters in the cavity of the pelvis is 12 centimeters. Coming to the obstetrical outlet. So we have described our outlet already. That is, we said it starts from the sacrum, the tip of the sacrum, then pubic symphysis anteriorly, then you have the spines, the ischial spines, and so the ischial spines here, okay, ischial spines, and in a woman there will be ligaments which connects the spines to the sacrum. It's called as sacrospinous ligament. So these are the structures that forms the obstetrical outlet, and this area is very important. It's called the plane of least pelvic dimension. So that is what the exam would like to know from you. What is the plane of the least pelvic dimension and its significance? So if there is any diameter of the plane of the least pelvic dimension which is affected, you can have a difficult labor. Understand? So you should know the plane of least pelvic dimensions. That's what I've described now. What are the borders? Then you come to the actual diameters here. So in the diameters, what you find is, so we said that in the inlet, we talked about 3 diameters. We said the anteroposterior diameter is 11, the transverse diameter is 13, and the oblique diameter is 12. In the cavity, we said everything is 12. So down, the easiest way is put everything reverse. That is, anteroposterior was 11 in the inlet, make it 13 here. So anteroposterior diameter in the outlet is 13. So the transverse diameter will be 11 and oblique will stay as 12. So this is the thing I was telling, it's easy to memorize. So when you talk the inlet, it is 13 transversely, 11 anteroposteriorly, and 12 obliquely. In the cavity, all the diameters are same. At the outlet, important is obstetrical outlet, you find the anteroposterior is more, that is 13, then the transverse diameter is 11 and 12. So you have to remember 11, 12, and 13. That is the easiest way to remember. There will be small variations in text, but easiest way to remember is this. Remember it as whole numbers. Somebody will say 12.5 or something. So easiest way to remember is 11, 12, and 13. So that's about the obstetrical outlet or the plane of the least pelvic dimensions. Then comes the anatomical outlet. So anatomical outlet, though it is not very obstetrically significant, but this is one thing which you can easily measure. So we will measure this during in a patient's labor. You may think about measuring the pelvis is okay. So what we do is from the tip of the coccyx to the pubic symphysis to the ischial tuberosities. This is what you are seeing. So one we can do is we'll put our fingers between the subpubic angle, that is between the 2 pubic bones, and see if it is wide. So I'll come to that later. Then again you will put your 4 knuckles between the 2 ischial tuberosities and see if it is fitting in. So between the inter-ischial diameter, there is a transverse diameter of the outlet. The transverse diameter of the outlet is normally around 10 to 11 centimeters. It should not be less than 8 centimeters. So it's about the transverse diameter at the anatomical outlet that we can measure. Understand? The interspinous diameter again we can measure. So when you can find through the 2 spines, and you can assess the area between the 2 spines with the 2 fingers on 2 spines, to the middle and the index finger on the 2 spines. You can find out the distance to the interspinous diameter. The interspinous diameter again is around at least 10 centimeters, we discussed. So it should be, we said it should be, the transverse diameter should be around 11. So at least should be 10. So less than 10 can cause problems. So you know, all these are some of these diameters that we talked about. It's the important anteroposterior diameters, both at the inlet as well as the outlet. Then the transverse interspinous diameter in the plane of the least pelvic dimensions. All these are critical diameters. So if there is a reduction of even 0.5 to 1 centimeters from the normal, there can be problems in labor. That is when we say there is a contracted pelvis, when there are important diameters are reduced by 0.5 to 1 centimeters. That is the importance of knowing all these diameters. So it is about the plane of least pelvic dimensions. Then you have
Excuse me, sir.
yeah. Yes. Hello.
So please continue.
Okay. So that's about we talked about inlet. We talked about two types of outlet. We talked about the cavity. We talked about the greater plane of the greatest pelvic diameter, plane of the greatest, the least pelvic diameter. So these are things that usually diameter, assessing the pelvis or knowing the pelvis is adequate. We use these to help us. Then comes the other parts that we check in a pelvic assessment. As first I told you is the pelvis is actually directed anteriorly like this. So when the pelvis is directed anteriorly like this, the inlet, there is a plane of inlet for the superior straight of the pelvis, as I told you. The plane of the inlet will make an angle with the transverse. So if I put a transverse like this, so there's a diameter that is formed between this and the plane of pelvic inlet. That angle is normally 55 to 60 degrees. And that is a normal angle of inclination. It's called the inclination of the pelvis. This angle that is measured by the plane of inlet. What the angle the plane of inlet makes with the transverse at that point. Just put a transverse there. That angle is around 55 degrees. So it's around 55 to 60 degrees, the angle of inclination of the pelvis. This is important. Then comes as said subpubic angle. So this is the pubic arch. So here you can see the pubic arch in a female is broad like this. Understand? Whereas in a male it is pointed like this. Pointed. So here is a broad this thing, and the advantage is you can put two fingers like this between this. So this can be done in a woman who is in labor. You can assess whether the pelvis is okay. So if I can't put two fingers, it means the pubic arch is more narrow. So subpubic angle is important. A pubic angle of more than 85 to 90 degrees says that it is a good female pelvis. If it is less than 85 degrees, it can give you problems. Understand for the delivery of the yes.
Sir, sorry to interrupt, but a student had asked a question.
Yeah.
The student had asked, sir, exactly what do you mean by conjugate?
Yeah.
Could you answer that, sir?
Conjugate is what we call as the diameters. The diameters are normally we refer to as the conjugate. Listen, we talked about three conjugates here. That is the conjugator, vira, or true conjugate. All these are Latin terms. Conjugator, vira is a true conjugate. Then you have the obstetrical conjugate, and you have the diagonal conjugate. So you just borrowed the terms from there. That's all. Otherwise, it's just it is just diameters like the others.
Okay,
The anteroposterior, these three are called the conjugates. Understand? So diagonal conjugate is what we measure, and the other two are what we deduce from that.
Okay,
is
sir.
it
Thank
clear?
you, sir. Yes,
Okay.
sir. Yes, sir. Please continue, sir.
Okay. So this is about okay. We're talking about subpubic arch. The arch should be more wider with a good angle, more than 85 to 90 degrees. That's what one of the things that we measure. That is about the subpubic angle. Then we discussed about. Then other things that you can see in the female pelvis, again you can see the sacrosciatic notch. So all of you are familiar with the sacrosciatic notch. What lies below the posterior? So this is when I say the iliac crest. This is the iliac crest. This is the anterior superior iliac spine, anterior inferior iliac spine, posterior superior iliac spine, and posterior inferior iliac spine. What lies below the posterior inferior iliac spine? That notch is the sacrosciatic notch. So again, we can feel the sacrosciatic notch when you do a vaginal examination. You put your fingers and try to see how the sacrosciatic notch is. It should be wide and shallow. Wide and shallow. It should allow your fingers to nicely be able to put the fingers into the notch. Then it's called then you say it's a wide and shallow. It should not be too deep. So wide and shallow sacrosciatic notch is good. That means the pelvis is good. Like that is good for vaginal delivery. That's the sacrosciatic notch. Then we said about the ischial spines. We said it's a very important landmark for obstetrician. You can see this. This is the sacral ischial spine. Ischial spine. Understand? It's on the ischium. So I hope you remember the bones you have learned in anatomy. So anteriorly is the pubis. Posteriorly it is the ischium. The ischium has a body and again the rami, like the pubis. In the body, you have the ischial tuberosity here. Inside part is the ischial spine. You can see posteriorly and interior is the ischial spine. This we can palpate. The ischial spine, which is blunt, it is not very pointed. It is blunt and it is not projecting too much. It is good for a female pelvis. for a delivery. Understand? So ischial spine should be blunt and it should be smooth. So and it should not be too much projecting inside. That is a good pelvis. Then comes this pelvic side walls. So you will put your fingers and feel the side wall, that is the inner part of the ischial bone and a part of the this thing. So you can find the pelvic side walls. If it is straight, you are happy. If it is divergent, okay. But if it is converging, you are worried, because a converging side wall means difficulty in labor. There again, you can face a difficulty in labor. It's more feature of an android type of pelvis, or the male pelvis, which can give you some obstetrical problems. So you can always also feel the pelvic side wall. Then again, one important thing that you see in labor is the sacrum. You try to palpate the sacrum. You put your hands like this and palpate the sacrum. So a sacrum which is short, understand, lengthwise it is short, and then it is broad and wide, you're happy. That's a good sacrum. The curvature is smooth. It is not an abrupt curvature. It is a smooth curvature with wide and shallow. Then you are happy with the sacrum. So that's a more of a gynecoid sacrum, which will be good for a delivery. So you will put a hand inside and you will try to palpate the sacral curvature. How the sacral curvature is. It's a well-curved curvature having a broad sacrum. Understand? And short. If it is too long, again you can anticipate problems. And sacral promontory is reached with difficulty in a normal pelvis, because we said that if the sacral promontory comes forwards and is very prominent, then it becomes an android type of pelvis. Here, because the sacral promontory is not too much projecting anteriorly, you may find it difficult to reach the promontory. If you find it difficult to reach the promontory, or you can't reach the promontory also, you are happy in an obstetrician, because that means the pelvis is good. Understand? So sacral promontory which is reached with difficulty is good. These are again important points in pelvic assessment. So these are the two things we try to check in women with all the soft tissues around. These are the things that we try to palpate. You look for the sacrum, you look for the sacrosciatic notch, you look for the ischial spines, and you look for the side walls, then you look for the subpubic angle. So all these things are, in a way, to an extent, you can find out and you can anticipate difficulty, or you can say everything is okay, the pelvis is adequate. So these are the other things that you look for in a maternal pelvis. So coming to the, if you want to know what the obstetrical significance of all this is, so once a patient is in a labor, so you have to decide whether this patient can deliver vaginally. So if you know all these things, then you can examine the patient for abdominal examination, then a pelvic examination. You can say that you can at least the pelvis is okay for a delivery. Sometimes you find that there is a pelvis which is doubtful, a contracted pelvis, or you find that there is a mismatch between the fetal size and the pelvis of the woman. Then you say there is a cephalopelvic disproportion. When you know this, then you can anticipate how the delivery will be. Suppose you find that there is a problem, then you can be more alert, or you can decide for cesarean section directly if there is a severe form of contracted pelvis. That is the importance of knowing the pelvis, maternal pelvis, actually as a practical importance is concerned. So for exams again, you should know all these diameters. Many of these diameters may not be practically important, they may be more of historical importance. So examiner would like to know from you whether you would like to know this diameter or that diameter. So the easiest way to remember, as I told you, is remember the 13, 11 and 12 rule. So you use that anteroposteriorly. What is anteroposterior is 11, the widest is the transverse 12, and oblique is 12. So, when you come to the mid cavity, everything is the same, 12, 12 and 12. When you come to the outlet, anteroposterior is 13, then transverse is 11 and oblique is 12. Then we shall talk about three diameters in the anteroposterior brim. So there are three diameters, that is 10, 11 and 12. So obstetrical is the smallest, which is 10. True conjugate is 11, and what we measure, the diagonal conjugate is 12. This is about the diameters of the pelvis. I hope I have covered all the aspects of important aspects in maternal pelvis. Yeah. If there's any questions, I'll be Happy to answer.
So that brings us to the end of today's session. We would like to express our sincere gratitude to Dr. Nurul for sparing his time amidst his busy schedule and taking such an enlightening and informative class for us, and also in such a simple language. Uh, Hearty thanks to you, sir. We genuinely hope this session was useful to all those who have joined us today. A point to note, tomorrow we have a session 2 on the mechanism of labor by Dr. Sajila Vimalraj. We hope we are happy to welcome you all to join us tomorrow at 4 p.m. That's all,
Thank
and thank you all once again.